Lastly, we have a topic about cholestatic liver diseases, the principles of management, which will be given by another pride of Pakistan from United Kingdom, all the way from University Health Southampton, Dr. Nadeem Tehami, who is an expert in especially the pancreatic biliary diseases and expert in EUS and ERCP also. So it will be a virtual talk by him now. Can you play that? So he's available online for the question answer session.
Assalamu alaikum and good day to you all. Many thanks once again to the organizers for their kind invitation. Please do accept my sincere apologies for not having been able to attend this fantastic program in person, and I really missed your company. I believe this would be the last talk of the last session of the conference, and majority of you would be suffering from cognitive overload at this stage. Well, I'll be lucky if there are still audience present in the room and listening to the talk. Those who are, I'm really grateful. I promise that I'll try to keep this talk relevant. I have no disclosures. It's a big topic, and I would therefore may have to offer you just a whistle-stop tour, but mainly focusing on immune-mediated cholestatic liver diseases and focusing on some practical take-home points. I will also like to see if we can dispel the myth of existence about overlap syndrome. In fact, let me begin my talk by sharing this position statement from International Autoimmune Hepatitis Group, where they concluded that patients with autoimmune liver diseases should be categorized according to the predominating features as autoimmune hepatitis, PBC, and PSC stroke small duct PSC respectively. And those with overlapping features are not considered as being distinct diagnostic entities. So essentially what they're saying is that overlapping syndrome do not exist. And the autoimmune hepatitis scoring system should not be used to establish a subgroup of these patients. So these are quite strong, powerful statements and speak for themselves. Now, the topic of discussion, cholestatic syndrome, can be divided into neonatal, adult, but we know the only truth known to mankind is pathology. So based on that, we can classify them as bilirubin stasis or cholate stasis. Importance is that in complete and early obstruction is the only place where we would expect to find bilirubin stasis, as opposed to mixed bilirubin and cholate stasis, which can be seen across the spectrum of presentation. As briefly mentioned, there are a number of cholestatic syndromes, immune-mediated, non-immune-mediated, genetic, idiopathic, infectious, vascular, and malignant cholangiopathies causing cholestasis. But in the interest of time, we will focus our attention mainly on the four common causes of cholestasis. When we talk about the pathogenesis, we know that there's an underlying immune-mediated liver injury, and all these spectrum of diseases tend to share a common pathway, which progresses through the same pathophysiology of inflammation and fibrosis after an induction of cholestasis, which can be triggered by several factors, infectious, environmental, underlying genetic abnormalities, or even disturbance of the intestinal microbiota. These conditions tend to share a disease kinship due to underlying immune biology. We do not know for sure the exact etiology, but we recognize that in certain individuals who are genetically predisposed in certain environmental conditions could lead to development of one of these conditions. These conditions do tend to share a lot of phenotypic features, and this is where the problem of overlap syndrome comes in. In terms of the principles of management, which remains pretty much the same, the focus is a goal-driven care. So after initial diagnosis, we try to risk stratify a patient, stage the disease so that we know how to monitor them and sort of what's should be the interval of the follow-up. We want to manage their symptoms actively to prevent complication of the disease, and then enroll them into the surveillance program, as our risk is a big C word here. It won't be a surprise to you recognizing a typical patient with PBC, but emphasis here is to risk stratify patients who are at risk of developing rapidly progressive disease, and as a result may end up developing cirrhosis. So we tend to focus or categorize those at high risk who are diagnosed early in their life, before the age of 50, male patients who do not respond to the first line treatment, and or those who have advanced fibrosis at the presentation. So once patients are diagnosed, they are started on treatment. It's really important that they are started on the appropriate dose of the ursodeoxycholic acid, which is 13 to 15 milligram per kilogram body weight. If they do not respond, then the second line available treatments such as obeticholic acid or bezafibrates could all be considered based on the risks stratification and scoring. We want to manage their symptoms actively to prevent complications and ensure that our patients are able to enjoy a decent quality of life. Then risk stratification is important because the complication can significantly impair a person's quality of life, and accordingly these can be staged, and the disease can be surveyed. This data was quite powerful because at one stage, until one stage, the alkaline phosphatase was the only surrogate marker for patients with PBC. But we also know that it's probably the only condition where we tend to refer patient for consideration of transplantation early when their bilirubin starts to go off, even when they have no significant underlying fibrosis. And that's what's essentially shown by the data that even with the normal range, the bilirubin levels can estimate the survival of these patients. We have the first, second, even third line medications available. Second line, obeticholic acid. Now, the step not been shown to provide a significant improvement in terms of the transplant-free survival or overall outcome. The bezafibrates can be used with ursodeoxycholic acid as second or even third line medications. They are cheap. They're safe as per recent meta-analysis, compared to obeticholic acid, which is expensive, not widely available, and certainly have side effects in form of pruritus. I'm not going to discuss pruritus. You all know the step ladder pattern, how to manage patients' pruritus. The problem we have in clinical practice is the management of fatigue, which is mostly multifactorial. The message that we want take away is that it's important to rule out any associated underlying cause which may be contributing. Unfortunately, there isn't any medication available which is recommended or has maximum maximum positive outcome in this group of patients. Unlike pruritus, intractable fatigue is not a valid indication for transplantation, and it does not really improve after transplantation. There are different ways we can approach these patients. One such approach is using this trace, where we treat their symptoms, try to ameliorate the exacerbating factors, and counsel our patients and help them to develop a coping strategy. This is really important because then we can maintain a good rapport with our patient, have an empathy, and then get a positive outcome after managing a patient. Some pitfalls: imaging are not used for the diagnosis of PBC. However, we want an index ultrasound scan, and also may want to do a fibroscan at the next presentation, which can help us in terms of sort of monitoring the progression of our patient's disease, but it does not have any role in terms of diagnosis. We will talk about histology a little later, but we know that patients may have interface hepatitis, which is not pathognomonic sign of autoimmune hepatitis. I shared the International Autoimmune Hepatitis Group consensus statement, essentially stating that overlap syndromes do not exist. We know that the biochemical response to treatment is the simple measure for risk of future disease progression, and ultra-deoxycholic acid should be a weight-based treatment. Guidelines says that patients with PBC should be offered structured long-term follow-up, recognizing different patients have different disease course and may require different intensity of follow-up. There are numerous risk scores proposed for patients with PBC. However, there is insufficient evidence to recommend one over another on the grounds of head-to-head data. Moving on to PSC, which is regarded as a black box in the world of hepatology. We diagnose patients who have cholestatic liver enzymes unexplained by other um, etiology. Patients may have characteristic uh, changes on MR cholangiogram, such as beading, appearance of the ducts, and when we have ruled out the secondary causes of sclerosing cholangitis. Unlike PBC, we do not have a typical patient with PSC. We do see it in patients who are young, but unfortunately, we see quite quite an heterogeneous spectrum of disease, from someone presenting early to someone presenting quite late with significant complication of the disease. And this is what is shown by the data, that it is unfortunately a condition with significant mortality and sort of reduced survival. Despite all this, unfortunately, it does not seem that majority of these patients are referred for transplantation, consideration of transplantation early. Different sort of phenotype, or two main categories, like one is the large duct and the other small duct PSC. From the British cohort, also seems that the survival of those who have intrahepatic versus extrahepatic and combination disease is seen to be quite worse. Um, Patients, given that we don't have effective treatment available, and when we are faced with these patients who may present with different symptoms, we just have to tailor the treatment as per their symptoms. But importantly, that we should consider a transplantation as early as possible, only offer them an intervention if it has a clear therapeutic goal. Also, deoxycholic acid, although not evidence-based, but is still used. There are some number of other treatments in pipeline who seem to have a potential positive impact in the future. A brief couple of slides on ERCP in PSC. As mentioned, we only tend to use it when we have a clear roadmap with a clear therapeutic strategy, and therefore we limit it to symptoms who are symptomatic with a dominant stricture. Decisions are based in after discussion with colleagues in MDT, so that we are not going to disservice our patient. We need to mitigate the risks of complication. Unfortunately, it is a condition which carries very high risk with ERCP. We tend to prefer balloon dilatation over stenting. Tissue sampling helps to exclude underlying malignancy, and we can use our advanced available diagnostic modalities to get the diagnosis right as soon as we can. So patients who are not jaundice and have no dominant strictures, or may have diffuse intrahepatic stricturing, we tend not to offer ERCP. It can be offered to patients who have indeterminate stricture or suspicious IgG4 related disease, especially if we can offer them cholangioscopy at the same time. Patients with dominant stricture, jaundice, cholangitis would certainly could benefit from ERCP intervention. But obviously important to bear in mind that our job is first to do no harm. It becomes even more challenging when we started to look at the IgG4 related sclerosing cholangitis with PSC. Although IgG4 related sclerosing cholangitis respond to steroids unlike PSC, these are two distinct entities histologically, and it's usually tend to be a dominant stricture in PSC compared to IgG4 related disease, which tends to sort of start off as an autoimmune pancreatitis and then seems to involve the common hepatic duct and becomes, it's like more of a diffused disease. but they do not tend to have so IgG4 related hepatopathy is very uncommon, whereas patients with the primary sclerosing cholangitis do tend to have intrahepatic multifocal stricturing and beading appearance on the MRI scan. So diagnosis can be really challenging. The patient where we are concerned because who have deranged liver blood test, cholangitis with dominant stricture, important to ensure that they don't have a cholangiocarcinoma, because that the treatment might be completely different, may need refer for transplantation early. They do need surveillance scan for gallbladder polyps, and if there's a diagnosis of cholangiocarcinoma, then that again needs to be discussed in MDT and managed accordingly. Patients who have associated IBD need colonoscopies yearly, and those who do not have IBD may need colonoscopies every 5 years. Not to forget the importance of associated metabolic bone disease, which can also have can impact on the quality of life of our patients. We started off the talk by stating that these overlap syndromes do not exist, and one of the reasons is because this overlap is not only seen in immunology but also in radiological features, histological features, and patients may also have a biochemical overlap. So it's essentially a spectrum of diseases. It may be one predominant condition and have features of other conditions. Our obsession with some common phenotypic feature is what essentially drives this diagnosis of overlap syndromes. For example, interface hepatitis is seen in all three different conditions. It's not pathognomonic of autoimmune hepatitis alone, which some may consider it. So with autoimmune hepatitis, they may also have elevation of alkaline phosphatase, some florid duct lesions or ductopenia in few cases, and may also have positive AMA, but do not develop PBC when they are followed for over 2 decades. And PBC patients, as you mentioned, may have moderate or even severe intraphase hepatitis with plasma cells and a biochemical overlap as well. So PSC, autoimmune hepatitis, follows a course akin to classical PSC and may have concomitant IBD. The rate of disease progression may be similar, albeit lower risk of cholangiocarcinoma. We do not rely entirely on the biochemistry. Patients tend not to respond to the immunosuppression. And from the pediatric studies, we know that the 50% of those who are diagnosed as autoimmune hepatitis in the pediatric clinic turns out to be PSC or evolve into the PSC. The same goes for the PBC and IH group, who've been sort of considered to have a shorter time to transplantation in the studies. And it all comes down essentially to optimizing their first-line treatment, because the impact of immunosuppression is unclear, and the randomized controlled trial have not shown any evidence of budesonide. From transplant outcome point of view, the overlap presentations tend to be younger at the time of transplant, essentially because they're misdiagnosed, late diagnosed, and the complications are presented late. So with the greater incidence of recurrent PBC and PSC post-transplantation, however, autoimmune hepatitis alone tends to impart greater risk of recurrent disease after transplant. I am sure I don't need to emphasize the importance of nutrition in the liver disease, but malnutrition is one of the extrahepatic complications of cholestatic liver disease, which can negatively impact quality of life. And achieving nutritional optimization in these patients is an essential component of their management. So in conclusion, ladies and gentlemen, chairpersons of the session, we need to be aware of the challenge and the opportunities with cholestatic syndrome spectrum. Needs to be risk stratify these patients so that we can offer them the available second-line treatment as soon as possible, which unfortunately is not the case with the PSC, which requires completely a different set of workup and management approach. The surveillance for cirrhosis remains pretty much the same, and the cancer risk is what drives the surveillance follow-up for these patients. Management is all about optimization and stratification in consultation with the multidisciplinary team. So thank you for listening, and I will look forward to question and answer session.
Thank you, Dr. Nadeem, for once again an excellent talk. This brings us to the question answer section. We have one question from the audience with Professor Dr. Shahid Sarwar from Dr. Kanwal, JPMC. How beneficial penicillamine is when the patient has already developed cirrhosis? Mike.
Yes, you do treat these patients for chelation because it depends the stage of cirrhosis. Is it a decompensated cirrhosis or a compensated cirrhosis? And we know that compensated cirrhosis takes time to evolve into a decompensated cirrhosis. So you will always treat unless patient has signs of impending liver failure. That is one situation where treatment is not going to help, and delaying transplant will mean very high mortality. Otherwise, there is no question about, obviously chelation will mobilize the copper from the hepatocytes, reducing the damage, and at least will prevent the further progression of the disease.
Dr. Bilal, I had a question from you. Just a couple of questions. Cost is a major issue in Pakistan, and with regards to that, with the systemic therapy improving with time, do you think, is there any role of tear at the moment because the treatment with the systemic therapy is approaching? That was question one. And the second question is, there was a trial that was published last year, the Orient 22 trial, in which they used sintilimab and bevacizumab biosimilar, and they are showing results quite similar to the atezobev at a fraction of a cost. So do you think that's something that we can use in Pakistan, and do you have any experience of it?
We don't have, for the second, we don't have experience in the US about it, but again, the concept is that a lot of these medications can work and will work, right? Again, these guidelines are American guidelines or the European. We have to come with our own guidelines based on your own experience, like what is going on in Pakistan. Maybe sorafenib is as good, like, as compared to, but these are options available now. The talk was systemic therapy. Again, there are a lot of patients with improvement of radioembolization. We are using local regional therapy if the patients are candidate. We have seen even patients with portal vein involvement, and some of these, responses with radioembolization is correct. It's very impressive. So in tumor board, our oncologists, interventional radiologists, we all sit together and see what is best for the patient. And there are patients we have tried, like, radioembolization and then start systemic chemotherapy a little bit later. So we are always tried first based on their performance status, based on their child's classification and their liver function, the local regional therapy as the first option. And radioembolization has been, utilization is much more in our center, using it more and more. So again, that is always an option.
Another question from the audience from Dr. Saleh. How to choose cases of portal vein thrombosis to anticoagulate, and who should not be anticoagulated? And how often do we see the small bowel ischemia with portal vein thrombosis?
Okay.
Two questions.
The last question first. I would say that the small bowel ischemia can occur specifically if the extent of the thrombus and it is completely occluding the portal vein, along with the splenic as well as the mesenteric vein involvement. And it is a catastrophe in the setting of the cirrhosis setting. But I have not touched upon the otherwise thrombosis, and yesterday I got a call from one of our colleagues who has at Islamabad almost completely dissected the whole small intestine due to severe portomesenteric thrombosis, because the gut was, all of that were gangrene, and took out the third part of duodenum and the colon as stoma. So that was a few months ago, and luckily the patient is still surviving. That's important. So the ischemia, the venous ischemia can occur, but more so it's the arterial ischemia, or once it's complicated by volvulus and all that, which would lead to that. So normally in cirrhotic patients, luckily the small gut ischemia or the mesenteric ischemia is less common. However, we see thrombosis pretty often, I would say, or not so uncommon, I must say. The other thing is that I would anticoagulate all of them, specifically if they are a liver transplant candidate, The reason is simple: if you do not anticoagulate, you need to follow them more frequently. One, specifically if they are small thrombi, the extent is small, or they are partial one, you can still follow them up. The other thing would be if they progress, then what happens? Because if they develop the chronic portal vein thrombosis, though this may leads to the complexity of the later on liver transplantation as well. So and one more thing is that whenever they develop portal vein thrombus, I believe that these patients must be seriously communicated one thing, that probably they need liver transplant now because their portal hypertension has advanced significantly. So I hope I have answered your question.
Okay. Any question from Dr. Nadeem? Okay, so with this, I will
Is
move
Dr.
now.
Nadeem Tehami online?
Yes, yes, yes. So, Mr. Chairperson, can you please give your comments and conclude?
So just to conclude the session, I think they were all excellent talks. Dr. Shahid Sarwar with the mentioning of this exciting new gene therapy that's coming up. Dr. Saleh with the fine balancing act of the pro and anticoagulants. I really like the picture with the elephant balancing on that stool, you see. It's stuck on my mind. And Dr. Bilal Hamid, guiding us through this nebulous area of systemic therapy. And Dr. Nadeem with his wonderful guiding us through this nebulous area of systemic therapy. And Dr. Nadeem with his wonderful guiding us through this nebulous area of systemic therapy. And Dr. Nadeem with his wonderful guiding us through this nebulous area of systemic therapy. And Dr. Nadeem with his wonderful guiding us through this nebulous area of
Can we stop this?
And Dr. Nadeem with his wonderful guiding us through this nebulous area of
Can we stop this?
आप अपना mic.
Nadeem, we missed you. I think we missed Nadeem's presence with his vibrance and all that, but we can see him there. I think it was a wonderful talk and a difficult one at the fag end, but you did justice. And if there are no questions, I will just thank Dr. Najmul Sahar for hosting this session very well. It was the last session, and definitely it was beyond viral hepatitis and NASH, and Dr. Shahid Sarwar, as Riaz has mentioned, he put us through the diagnostic and treatment things. The vascular by Dr. Saleh was very succinct as always, and I think he answered the question very well as well. Bilal Hamid, of course, was a hard nut to crack with this systemic chemotherapy. The bottom line is that things that are available and things that are coming available, there is going to be improvement. But I think we need to do a lot more for screening. That's what's not your thing. But as gastroenterologist, I think the third leading cause of death, HCC being, that's a worrisome prospect. And we must do everything in our power to prevent that. And lastly, for the organizers, the chair, the scientific committee, the patrons sitting here, advisors, I think it was a very wonderful conference overall. You will have a closing session, but my 2 pence is that as a society, PSH now needs to look more outward than inward. I think we need to collaborate with other societies as it's a multidisciplinary everything. From fatty liver to HCC, you can see so many specialties being involved. And I think it's about time that professional societies come hand to hand with non-governmental organizations and the government, and we pressurize the government to act for the health of all, not 2030 or 2050. I think starting from now, and do whatever we can. So thank you very much, everybody. Very good session, and I declare the session closed.
For Dr. Nadeem, I just wanted to ask you this question, not related to this talk, but you shared a case of Merizi syndrome treated with ERCP in your tweet. How they treated it, apart from putting a stent in?
So you have a question, Nadeem, at long last.
I'm honored
So you have a
and thanks
question,
for
Nadeem,
asking.
at long last.
Although it's kind of beyond the remit of our discussion today, honored and
with
thanks
the,
for asking. I think you can have a session on the remit of our discussion. First question is diagnosing because again you can misdiagnose even with the available diagnostic modalities. And as you all know, obviously there are different types of them with the available diagnostic. So it's a difficult question just to as you answer in all know obviously the different types of them. But I think just one take home message would be that in this day and age, patients with MIDZ must just should not go directly for surgery without having a cholangioscopy. Patients with thank you for asking. Should not go directly for surgery. Can certainly without having a cholangioscopy and try to answer. So thank you for asking. Discuss this further on a separate forum. Can certainly chat or and try to answer more and discuss this further on a separate forum.
I think we can wind up now.
No, you have it. So thank you so much for patient listening. I know this is the
can
last
wind up
session,
now.
and just I will hand over the mic to Dr. Asad Chaudhary for concluding the PSH 2022.